But let's turn CPR to the side for the moment and talk about defibrillation. And I want to share with you some of the important concepts around who we defibrillate and why we defibrillate. And by defibrillation, I mean delivering an electric shock using a defibrillator. Now, it turns out not all cardiac arrests are the same. There are different heart rhythms that lead to cardiac arrest. One of them, which I shared with you briefly at the start of this lecture, is ventricular fibrillation. That's what it looks like. This is a chaotic heart rhythm where it looks like electrical noise. Another rhythm is called ventricular tachycardia. That's where the heart rhythm is going very, very, very fast. So these two rhythms are known as shockable rhythms. If a healthcare provider comes across a patient and discovers they are in either ventricular fibrillation or ventricular tachycardia, they need a shock. They need defibrillation. And this indeed is one of the key teaching points in ACLS, or Advanced Cardiac Life Support, the notion that you shock VF or VT, these patients in these heart rhythms. Now, those aren't the only heart rhythms of cardiac arrest. You could also have something called PEA, or pulseless electrical activity. PEA is a funny rhythm in that it can often look normal. If I just handed a physician or a nurse this heart rhythm strip, they wouldn't know if the patient was in cardiac arrest or not. It can look normal. But in cardiac arrest, there's no blood flow, despite the electrical rhythm looking normal. There's also a well-known heart rhythm called asystole. This is known in the popular sphere as flatlining. You may have heard this in movies or TV shows. Someone goes flatline. That means there's no electrical activity at all. Now, it turns out these two heart rhythms are not shockable. So using a defibrillator is not helpful if someone has PE or asystole. It's only helpful if you have a shockable rhythm like VF or VT. So I want to introduce this to point out that this is where it gets sophisticated. If you're going to use a defibrillator, you have to know which is which. I should say that is if you're going to use a manual defibrillator. It turns out automatic defibrillators, the ones in airports, gyms, and malls, can automatically identify which of these four rhythms a patient is in. These patients that need a defibrillation, an AED, will shock automatically, or if you're a healthcare provider and you see this rhythm, you know to give a shock. These rhythms do not need a shock. So with this one slide, I've taught you one of the most fundamentally important things about using defibrillators, the identification of the right rhythm that needs a shock or does not need a shock. Now it turns out VF and VT are very common for cardiac arrests that occur in the home or in public places. So that's why defibrillators are that important, because many patients who collapse suddenly are in either VFib or VTAC, I should say ventricular fibrillation or ventricular tachycardia. That's the reason for placing defibrillators in public places. In contrast, PA and asystole are less common in the public sphere, but much more common among hospitalized patients. So if someone collapses in the hospital, they may have PA or asystole, and that's more typical, and a defibrillator is less helpful when used in the hospital setting. So AEDs are crucial to save lives, and there's been a lot of work looking at this. However, finding them can be difficult. If you think about it, how would you know where the nearest AED is if your life depended on it, or the life of a loved one? There's no formal system. Now, an exception that proves the rule, you've often looked perhaps on an airport map, and this is not a real map, but a conceptualized map of an airport and airport terminals, and you'll often see markings on a map at an airport showing where AEDs are located. That can be very helpful. However, let's say you're in the lobby of a building and you see someone collapse. How do you know where to find the local AED? This is a big problem because you don't have very much time. There have been a number of recent exciting projects to try to figure out where AEDs are. Some of them have harnessed what we call social media, things like Twitter and other sort of internet-based means to find AEDs and create crowdsourced maps of where AEDs are located. I'll be honest, I don't pretend to understand social media. I'm getting a little too old for such things, but I can tell you that it's an incredibly powerful tool, and it may very well help the public health surrounding cardiac arrest. In Philadelphia, one such project was undertaken with some great success, and I want to now introduce you to Dr. Raina Merchant, who really led this project in Philadelphia, and she'll share with us a little bit on the notion of social media and AEDs.
Hi, my name is Dr. Raina Merchant, and I'm an emergency medicine physician at the University of Pennsylvania. I'm going to share very briefly with you some information about a life-saving device which you could use in the event of a cardiac arrest. So this device is the Automated External Defibrillator, or AED. So AEDs can significantly improve survival when coupled with CPR from less than 2% to 50%. So this is in cases when somebody stops breathing and no longer has a pulse. These devices are really easy to use, and there's data that's shown that these can be used even by people as young as 6th graders. They're located in public places all across the world, in places like grocery stores, supermarkets, government buildings, etc. And they're very simple to use. When you open the device, it'll start talking to you and provide both visual and audible instructions. There are about 1 million of these located across the US, and the big challenge, however, is that nobody knows exactly where all of them are located. So we've been using some new technologies, social media, along with mobile media and crowdsourcing, to find these devices and put them in a database so they can be available on a mobile app or for 911 centers. If you'd like more information about that project, you can find it at myheartmap.org. And you can also find a video there about how to use these emergency life-saving devices.
Hopefully you enjoyed hearing from Dr. Merchant. She's a real leader in this area of AEDs, and I think we'll be hearing more on these topics in coming years. And one of the reasons why defibrillation is so important and why finding AEDs are so important is the speed at which defibrillation is given also very much impacts survival. So very similar to the curve I showed you before, showing how time-sensitive survival from cardiac arrest is, there have been studies that, this one based in the hospital, looking at time to defibrillation. And what they found is if a patient has a shockable rhythm, VF or VT, getting a shock delivered within a minute or two is crucial to survival. If it takes 5 or 6 minutes to fumble around and find the defibrillator and run to the hospital room and shock the patient, you lose a lot of your opportunity to save a life. So this is why you can't wait for a paramedic to show up with a defibrillator. If someone's collapsed and there's a defibrillator on the wall, you gotta grab it and use it. The good news is most AEDs actually talk to you and tell you how to use them. They'll coach you. So it's not like you need to be trained in AED use. So for shockable rhythms, each passing minute makes a big difference. So one of the questions this raises is, should we have AEDs in our homes, like fire extinguishers? After all, what if your spouse collapses in your house and you call 911 and it takes 8 minutes for the ambulance to arrive? If you had an AED in your house, would it save more lives? Well, this has been looked at, and one large U.S. study showed no clear benefit from placing AEDs in patients' homes. After all, if someone collapses in their home and they're alone, an AED is useless. Also, if someone collapses and their spouse can't remember where they put that gosh darn AED that was misplaced a year ago, that's not helpful either. So there's a lot of devils in the detail on this issue, but I think we'll be thinking more and more about placing AEDs in more creative places, like in homes or at least in lobbies of most major apartment buildings. Now, there are a lot of challenges to the widespread use of automatic external defibrillators, and I hopefully gave you a sense of this earlier regarding public awareness of AEDs or public education. One of the real challenges is we don't have uniform instructions. There isn't uniform messaging around AEDs. It's dependent on the manufacturer and the location. So for example, I show you here a poster that we use at our hospital to instruct members of the public of how to use AEDs. These posters are not commonly placed, and more importantly, when placed, every hospital, every healthcare system has a slightly different design. Standard signage and messaging would be really helpful, but doesn't yet exist. It's also important to note that AEDs are expensive. Currently, most cost over $1,000 for each device, and price point is important. After all, if you're a small business owner, putting one of these on your wall for $1,500 may be cost prohibitive. Now, it's interesting because some municipalities and states actually require it, cost prohibitive or not. There are cities with ordinances stating if you have a certain number of employees or a building of a certain size, you need AEDs, but many do not. There's a federal law that supports AEDs in federal buildings, or I should say stipulates AED placement in federal buildings, but it doesn't specify how many. So there's clearly a lot of regulatory uncertainty, I should say, regarding AED placement. How many do you need? How should the messaging be performed? It's a complicated concept. And again, there are lingering concerns about liability. Some business owners feel that having an AED and not using it, or having an AED and using it wrong, may put them to more liability than not having one in the first place. This is an interesting and evolving area of the law, and I suspect in coming years it will be more of a liability not to have an AED than to have one. Now, we've talked a lot in this lecture about CPR and defibrillation. I want to share with you a little bit more about what is included in ACLS, or Advanced Cardiovascular Life Support. Beyond CPR and defibrillation, ACLS teaches about use of medications, and we use medicines such as epinephrine or amiodarone. Those are two commonly used medicines in cardiac arrest. ACLS also teaches about using a variety of airway devices to provide rescue breaths, and I showed you a bag valve mask in that video from my emergency department. In ACLS, we teach about intubation, which is placing a breathing tube into a patient's trachea during cardiac arrest. And there's other advanced therapies under consideration that are introduced briefly in ACLS, such as the notion of putting people on cardiopulmonary bypass or the use of other advanced techniques. One such advanced technique, therapeutic hypothermia following cardiac arrest, will serve as the basis of Lecture 3 in this series. One of the key things I should tell you about ACLS is, aside from CPR and defibrillation, the evidence for using these medicines and intubation is poor, or I should say it's modest at best. The fundamentals of resuscitation care, that is CPR and defibrillation, remain the best evidence-proven ways of restoring life after cardiac arrest. Now, I want to share with you a couple of examples from the public sphere of prominent citizens who have had cardiac arrest that you may have heard of. This gentleman, Tim Russert, was a beloved TV correspondent who had a cardiac arrest in 2008. He had known coronary disease, and when he died in June 2008, this was all over the media and in newspapers, and there were many specials about him and his life and his work. In his case, he actually had a heart attack, a myocardial infarction, that quickly led to cardiac arrest. So this is one of the reasons for confusion with terminology. Sometimes heart attacks can lead to cardiac arrest, and in his case, he had both. He had an attempted resuscitation with CPR and defibrillation, but this attempted resuscitation failed, and we don't really know how long it took to get resuscitation care to him or how long it was to get an AED applied, and we worry very much about these things for people in the public. And Tim Russert, this was a tragedy. This was a man who was still in the prime of his life and a functional member of society and a father. He in many ways was a typical cardiac arrest victim, and it's these tragedies we seek to avoid. Michael Jackson's death was also a tragedy. He also was young and also still very productive in the music world. However, his cardiac arrest was somewhat complicated in that it was presumed from a respiratory cause, from a drug overdose. And this is a very complicated topic that, again, has been much in the media and is the subject of much legal action as well. So we're not here to talk about the details or alleged details of his cardiac arrest. What I want to share with you is that he also had an attempted resuscitation with CPR and defibrillation, and it also failed. One of the issues regarding Michael Jackson's resuscitation was that he had CPR performed in his bed. It was not a hard surface. BLS teaches that CPR is best performed on a hard surface so you can actually compress the chest and not just compress a mattress. And this will be discussed in some detail, not Michael Jackson, but rather CPR quality, with some detail in Lecture 2 following this lecture. A third famous cardiac arrest that's worth a brief mention was this unfortunate woman, Terry Schiavo, who had a cardiac arrest in 1990. Now, she was a young woman, and she had a cardiac arrest that resuscitation was successful. So she was restored back to life and to a certain degree back to healthy body function. Unfortunately, as is typical for many victims of cardiac arrest, she had crippling brain injury following her resuscitation. And much to her family's pain and suffering, I believe, her case was bandied about in Congress and in the media. There were questions about whether she was truly brain dead and whether life care should be withdrawn. What was a very private matter, unfortunately, became a very public matter. And eventually, a care was withdrawn for her, and she passed away. Whether or not she was brain dead or not, again, is not the topic of discussion today, but rather to illustrate the fact that many victims have brain injury following cardiac arrest. And we'll be talking about that issue in Lecture 5, the final lecture in this series. Now, One other person I want to bring up, because he illustrates other aspects about cardiac arrest. This is Mr. Mwamba, who is a footballer, as the English might say, a cardiac arrest victim who was a professional soccer player, as we would say. He had his cardiac arrest on a soccer pitch in England, and in a very public way, while the cameras were rolling, he had a cardiac arrest and received CPR for a prolonged period of time. He had over 70 minutes of cardiac arrest and CPR, but eventually his heart was restarted after a heroic effort. He also received a treatment known as therapeutic hypothermia, which is whole body cooling, as I said, the topic of lecture 3 in this series. And despite being technically dead for over 70 minutes, he was restored to health and life. This is a screenshot from a Skype feed, or perhaps it was some other video feed, that he actually spoke to his many fans from his hospital room after his resuscitation to tell them that he was alive and well, and he wished them and he thanked them for their best wishes. And he's left the hospital successfully. And this illustrates an important point, that cardiac arrest, even if prolonged, does not have to be lethal. If good resuscitation efforts are performed and excellent post-arrest care is given, people can be restored to life and functional health. And I want to end with the concept that cardiac arrest science and treatment is entering a very exciting era. We're seeing broad implementation of AED programs, and this is increasing survival around the United States and indeed in many countries in the world. There's this notion of hands-only CPR, which I promise to go into more detail in the next lecture, which has removed many barriers for bystander action. By removing mouth-to-mouth, we have a simpler form of CPR and a form that is less distasteful to some providers. In addition, dispatch-assisted CPR, or 911-assisted CPR, is greatly improving bystander participation, especially for bystanders who aren't trained in CPR. And I think there's a growing realization, I hope there's a growing realization, that cardiac arrest is not hopeless, that there's been a shift in perception is occurring among healthcare providers that we can do something about cardiac arrest, that through AEDs, through better CPR, we can save more lives from this dreaded illness. And part of this realization is fueled by post-resuscitation therapies, such as therapeutic hypothermia, and improved use of heart catheterization. That's, in layman's terms, angioplasty, to improve outcomes from cardiac arrest, where coronary disease is one of the causes. And to give you an illustration, the woman wearing the black jacket and salmon-colored shirt there is a cardiac arrest survivor. She was a woman in her 40s who had a cardiac arrest while driving in the state of New Jersey. She collapsed. We cared for her at our hospital. And this is her and her nurse savior in many ways. The woman in the middle there was the nurse who took care of her in the emergency department. She's now been restored to life and health and is back with her family. And here she's pictured at one of our resuscitation courses with myself and some of my colleagues and the nurse who took care of her. So we have many wonderful stories now of cardiac arrest survivors, and they're helping inspire us to do greater and greater things to improve outcomes from sudden cardiac arrest. So I hope you've enjoyed this introductory lecture in this series on resuscitation science. To give you a preview of what's coming next, in our next lecture we will be delving deeper into CPR itself and rethinking CPR and what it means to provide high-quality CPR. In lecture 3, we'll be talking about a post-arrest care therapy known as therapeutic hypothermia. That is to say, when people's pulses are restored, what can be done to bring them back to full health and life? A very interesting topic with great attention in recent years. Following that, in lecture 4, we will have a guest lecturer, Dr. David Gajewski, one of my colleagues at the University of Pennsylvania, who will be sharing with us some exciting thoughts about the future of cardiac arrest care and resuscitation science. Finally, in our last lecture in this series, we'll be talking about survivorship and some of the end-of-life issues that come up after survival from cardiac arrest for both victims and loved ones. So please join me in the upcoming lectures in this Coursera lecture series on cardiac arrest and resuscitation science. Thank you very much.